To This Week in Medicine. We took a little hiatus for a couple of weeks, hoping that with summer we would have decreased news to report and not do these as frequently, but that is not the case because of Omicron, so welcome. We're still working on our Foxhall Foundation education mission with travel, but travel with masks, so we're doing talks about the benefits of stroke prevention. We still have our center open, and Carrie's doing a bang-up job with nutrition, as you have seen in her recent videos. And we have active master's classes, programs for patients with movement challenges like Parkinson's disease, and adult movement classes, as well as those for children. This is our center, and this is what the inbox was like recently. Everybody's saying, I just have a cold, and people are pretty surprised because they also thought they had allergies. And then when they started testing, maybe because they had a fever, they found they had a positive COVID antigen test. So sure, it's just a cold. Maybe it is just a cold. Maybe that's what the new Omicron is. It's probably not allergies anymore because spring allergy season is over, although there is still pollen. Something in the inbox from a patient was wondering if they were a candidate for the new radiopharmaceutical prostate cancer treatment for metastatic prostate cancer. That's an exciting event that happened in July that's already been used in Europe, but thankfully here in the United States, treatment is starting for patients with treatment-resistant metastatic prostate cancer. Patients are wondering if they should take Paxlovid to Europe. That's a tough question because there's been some new data on Paxlovid or Paxlovid, the way I like to pronounce it. This medication had a lot of promise, and certainly we gave out a lot of prescriptions, but even the drug company announced in June, a couple weeks ago, that the benefits of this drug are really only in patients who are unvaccinated or those who have severe chronic illness, not really beneficial for patients who are healthy, who, because of our great Foxhall Medicine group of patients, means for most of you, it probably didn't help much. Omicron BA4 and BA5 are in the news, so we need to talk about that. Should you take Paxlovid is a good question. For some people, I prescribe it, and then we wait and see how your symptoms do for the first couple of days, because you should take it within the first 5 days of illness, not the first 5 days of testing, really the first 5 days of illness, because as we know, some of those antigen tests do not turn positive quickly. Sometimes it takes a couple of days for your test to be positive, even when you're sick. The question of masking or not masking, at this point, because of these bad actors, BA4 and BA5 in particular, it is so contagious. It turns out that the antibody immunity that you might have had from a previous recent infection with Omicron, let's say you got Omicron 1 or 2, that immunity is not going to protect you against BA5. So even if you did get Omicron 2 months ago, it doesn't look like it's going to work to protect you from getting infected. So right now, again, we are at a stage where if you make the personal decision that getting the infection will interrupt your life because you can't go on the trip you wanted to go on, it'll interrupt your life because you have an immunocompromised relative, then you probably should be masking. That's just the facts of this current virus. A lot of people do have negative antigen tests. They might do them 3 days in a row, and even a PCR test. They're still sick. So what do they have? It's possible you have one of these bad actors. A lot of people are still testing positive at home on a COVID antigen test, and that's probably the best way to go with this. Those tests are actually pretty valid, even though we're still getting some false negatives. These tests are still very useful, and a lot of patients tell me theirs are positive. So this surge doesn't seem to be ending, does it? We really kind of started at the end of March, and it proceeded through April, May, and June with a conversion from BA1 and 2 to 4 and 5A. So this would really count as a 3-month surge, which is not something we have seen before. Usually we did have some nice peaks and valleys when new mutations would come out. This has just been one mutation after the other in sort of a continuous 3-month surge. I really don't think it's declined that much at all. We're probably about 10 patients per week, maybe more in the past couple of days because of 5A. So the numbers are climbing again. But it really never went down like it used to. When we saw last year and even in 2020 were these peaks and then respites or breaks where the viral count seemed to go down. I remember not wearing a mask for quite a while in 2020 and 2021, but really we've been constantly masking for the past couple of months because we never had a letdown in the case rate. There is definite Paxlovid rebound. I just got an email today from the wife of a husband. He had his rebound about a month ago, and she just had rebound. Obviously, they're not related by blood. They're a married couple, but both of them have now had Paxlovid rebound. It really does happen. The quoted rate is 10%, but I'm really beginning to think this is more like 30 to 40% because I have patients tell me almost on a daily basis that they got rebound from this drug. We don't think it's due to resistant organisms. I think we really think that this may be due to not a long enough period of treatment. That 5 days, maybe it's not enough. Maybe it needs to be retested for 7 to 8 days. Again, this is based on some old data that Pfizer did submit to FDA, so we knew this could happen. Fauci just took a second round of Paxlovid, but it's still not FDA approved. So again, given the limited data on the efficacy of Paxlovid in healthy people who are not at risk for severe illness, which really could include people who've had their booster shots because that prevents severe illness, we wonder what the role of this medication is. We're really not doing many respiratory antigen antibody tests for the full panel. This was big a couple of months ago, but I have not sent anybody for this recently. You'll see this says May 22nd. We're now at July 7th, and I really am not sending these anymore because I think the virulence and contagiousness of Omicron 5 is so great that it's probably outcompeting all the rest of the viruses. So again, I gave out about 150 doses. Rebound, it used to be 10 to 20%. I'm beginning to think it's more like 30. Really only one adverse outcome. One patient had reduced dose for kidney disease. Just today I had a patient with kidney transplant. I don't think he should get Paxlovid at all, but he could get antibody therapy, BEBTELOVIMAB, which looks like it is still effective against 5A. Many fewer Paxlovid prescriptions were called in June for me, and also beginning weeks of July. It's just a couple of factors. People aren't really sick enough to warrant it. People are concerned about the rebound because that could extend your illness to 20 days because you'll be negative maybe at day 6, 7, 8, 9, 10, but the illness comes back at day 10, 11. Then you're waiting for another 5 days or 7 days to become negative again. So it really can, in a large percentage of people, prolong your illness, and you want this over with. Pfizer gave up on its recommendation on giving this medication to less vulnerable COVID patients because their data just doesn't look good. If you're a healthy person, you've had booster shot, and your symptoms aren't so bad, then it doesn't really do much for you. It's proven very beneficial in people at high risk of severe disease. So high risk of severe disease is definitely going to be people who are not vaccinated. But it's not as helpful if you're less vulnerable. If you're a healthy person who doesn't have a lot of medical issues or problems and you don't qualify, it probably won't decrease the severity of your illness. Remember, boosters definitely decrease severity of illness. So the clinical trial flopped in its primary endpoint goal, which was to give you symptom relief. So patients wonder, well, if I take Paxlovid, will I get symptom relief? They weren't able to show that. The endpoint that they achieved was decrease in severity of illness of people having to go to the hospital or death. So it certainly works for that, but again, so do booster shots. And if you're already a very healthy person, your risk of hospitalization or death is not great enough to really require something like Paxlovid. So what about BEBTELOVIMAB? A patient asked about this monoclonal therapy. Recent studies, here's one right here in the Lancet, did show that there is good neutralization against BA4 and 5. So all of the rest of the monoclonals studied, sotrovimab was one that we were using in December that used to be effective, not effective anymore, but BEBTELOVIMAB still is effective against BA4 and 5. I can order it, but I haven't yet. I did have a patient that I suggested today discuss with his transplant kidney specialist to see if this would be something for them. But I really don't see a big role for BEBTELOVIMAB unless you can't take Paxlovid for some reason. So what's happening with the mutations in Omicron right now. So clearly 4 and 5 are increasing throughout the world, and in the US in particular, probably today we're up to 60% of the circulating virus being the 5 variant, and 5 is even beating out 4. It's kind of like the United States has one big giant collective cold. That's what most people tell me when they call. They say, I think I have a cold, I have a cough, I have a very bad headache, I have a runny nose. And probably in some areas, there's as many as, 10 to 20% of people who have this infection right now. Negative antigen and PCR tests are not uncommon, so you can reference this article. I like reading Catherine Wu's articles in The Atlantic. They're always excellent. A negative COVID test has never been so meaningless. Unfortunately, the tests are not early accurate anymore. Omicron 5A, this is the big bad actor right now. It evades the vaccination booster effect and disease antibody neutralization effect. So if you just had COVID, your antibodies that we told you would protect you for 90 days from infection won't protect you for 90 days from BA5. So even though you may not be super sick if you get it, you could get it again. So you could have had COVID, Omicron 1, 2, or 3 2 months ago, and those antibodies that you make don't look like they protect or neutralize BA5. Same thing with the booster shot. That doesn't neutralize it either. What does that mean? That means that you can get it if you're not wearing a mask. Eric Topol published an article June 27th that got a lot of attention. It was quoted repeatedly in the media and by experts because he did a very nice analysis of the basic biology of BA5. He calls it the worst version of the virus that we've seen. That's pretty ominous, and it sounds bad, but you have to understand his categorization of what makes it the worst version of the virus. It's not worse than the one we started with in March 2020. That was the worst version of the virus I have seen because I clearly had patients who had it. It was a total body illness, systemic. It hit every organ. The reason that this is the worst has to be qualified. So we qualify it by saying it achieves immune escape. It escapes, again, the antibodies you might have just made from a recent COVID infection, disease antibody neutralization, and it escapes your booster antibodies that you get from vaccination. So it escapes. It has way increased transmissibility, as all of these mutations seem to. There was one study, and it's only one, and no one has said anything else yet, and I don't think the hospitals are reporting it, that maybe this 5A could get into the lung cells better. That is very important because that is what the first Omicron virus did in March of 2020. That first virus got into the lung tissue, not the bronchial tubes, which is bronchitis, which is what we currently have. So there was a suggestion through this one limited study that maybe it gets into lung cells. But we would expect to see that in patients in the hospital on ventilators again. And I don't think we're seeing that, but the next 4 weeks will tell us if that is true. And that may be why he's saying it's the worst version. But again, it's not the worst version. We can look at the worst version from March of 2020. FDA did authorize the BA1 vaccine that we were supposed to get in the fall to use it against BA5. But what they asked yesterday, on Wednesday, was that the manufacturers of the vaccines, particularly Moderna and Pfizer, try to incorporate some BA5 protection, and what they made is a BA1 that is supposed to be out this fall. So the question is, if they made a vaccine that's against BA1 or 2, how much protection will it provide us against BA5? And will BA5 still be here in the fall? Because this virus is now rapidly mutating, kind of like influenza rapidly mutates. So the question is, will this vaccine be worth it in the fall? Just to take a break from COVID, there is amazing news. Maybe some of this is because the national cancer meetings were held in June. Maybe some papers were held for release for these meetings that had outstanding clinical results. Regardless, this is great news in medicine. One I alluded to earlier was a treatment for metastatic prostate cancer. It was only available in Germany, and in fact, I did have patients go to Germany because they couldn't wait until July, this month, to get this special radiopharmaceutical treatment for metastatic prostate cancer, which is resistant to basically all other therapies. So that was announced this month in June. Luis Diaz, who used to be at Hopkins and actually went to the same medical school as myself, University of Michigan, now is at MSK, and he proved with a very interesting study that you could treat what was usually primarily treated with surgery, chemotherapy, and radiation with only chemotherapy. And he was able to basically, it looks like, cure this cancer. So this is remarkable because this is a completely different treatment. It's only in some rectal cancer patients, so you have to have the right type of rectal cancer genetically. But this was a breakthrough because this has not really ever been seen before, 100% remission rate for this rectal cancer. So this was more great news. There's a breast cancer drug called HER2, which is used for HER2 low metastatic breast cancer. Apparently, the results of this trial were so exciting that there was a standing ovation when the results were announced at the cancer meetings. So again, great news in oncology. So to dive a little deeper, PSMA metastatic prostate cancer, we can use this radiopharmaceutical, that's the radio part, that's the pharmaceutical part, and it's called Pluvicto. It's a radiopharmaceutical used to treat patients, very specific patients, with advanced cancer. That's called PSMA, prostate-specific membrane antigen cancer. It has to be resistant to chemotherapy and androgen, that means your testosterone deprivation therapy. So basically, this is a cancer that's growing autonomously and we can't get rid of it. But this drug does seem to get rid of it. When it spreads to other parts of the body, we call it metastatic. But this radiopharmaceutical can find these metastases and destroy them. It's already been used to treat other cancers. It is very promising, and it should be available in the United States right now. HER2 low metastatic breast cancer had a new treatment. Again, HER2 was so remarkable in its ability to extend life in patients who have this specific kind of breast cancer. That was a very, very remarkable evolution. So we should all take heart that clinical research trials in advanced cancer are progressing to the point where we should start thinking of some of these cancers as chronic disease states, which is a whole nother concept we can talk about some other time. Finally, this is the paper about advanced rectal cancer using primarily a chemotherapy treatment instead of standard chemo, radiation, and surgery. Back to T cells. I just want to remind everyone, we already talked about COVID, but I'm coming back to T cells so we don't forget, because I forgot about the T cells. So I'm coming back to remind you. Reminder on T cells and B cells via activation. B cells are our humoral immune response. T cells are our cellular immune response. We have two immune responses. B cells or antibodies is what a lot of people focus on in the media. They constantly talk about our B cell antibody response to vaccination. But don't forget about the T cells. That's why I'm bringing this slide back to remind you. We have a T cell or cellular immunity response, which is not easily measured. We can't just go and get a blood test for T cell response like we do for antibodies. But don't forget these T cells, because the immunity does work against COVID. In this little picture here, you have a picture of the SARS-CoV virus. You have antibodies, T cells that are trying to block very specifically on the outer portion. And then this virus tries to get into a cell, but it can't because the infection has been blocked by these cells that are attaching specifically to the outside of COVID. Don't forget your T cells. It definitely helps, and it helps to prevent severity. So one study that would suggest this was a recent study, June 7th, funded by NIH, that showed that if you have even no antibody response, that T cells can still protect against COVID. This was a study that was designed specifically to make sure there was no antibody response, just to see if those T cells alone, without antibody, could actually protect against COVID. And in this little research trial, which is very promising, it showed that yes, T cells do have the ability to neutralize COVID. So even if you don't have antibodies, even if you're worried that your booster was too long ago, we know that the way that immunity works and vaccination works is that a T cell response is still protective. Updating your travel plans. Remember, the U.S. government pays for Paxlovid. If you do want to take it with you to travel, you can, because you can't necessarily get it outside of the United States easily. Take your antigen test with you. The doctor's note you don't really need anymore, because a couple of weeks ago we got rid of the requirement that you come back into the United States with a certificate saying you are no longer contagious. But most people are going to not want to travel back from a foreign country to the United States while they have a positive antigen test. So take those antigen tests with you, because they really are your ticket to freedom and relief of a guilty conscience, because you don't want to travel while you have a positive antigen test for COVID. Also pack enough pills to account for 14 days that you might have to stay waiting to become negative. Wear the mask. Makes sense now that 5 is around, Omicron 5A. It would make sense to wear a mask on the plane. This is an old slide from May, again, demonstrating just how long this surge has gone on. This surge is a long one. So indoor masking is recommended. It's still recommended. It really never went away. To keep better numbers on this rebound to Paxlovid, I think it is a good idea to go to the website if you've had rebound and report it to Pfizer. The Paxlovid drug interactions, pretty much everybody knows now, but I will say yesterday the FDA allowed pharmacists to start prescribing this without a doctor's prescription. So FDA has now approved pharmacists are allowed to provide Paxlovid. You have to bring some paperwork in. You need to give your medication list. You need to have a positive COVID test to show the pharmacist. And then the pharmacist can prescribe this for you, but they do need to look at your medication interactions. And even though the pharmacists support this idea and say that they can do this because they are the experts in looking at drug interactions, there is a medical side to it as well. And that means your doctor's evaluation of the benefit of this medication for you. And that is not something a pharmacist is going to do. I just want to remind you about long COVID and that there really is a very clear interaction with the autonomic immune system, and that you will get some of these autonomic symptoms. Remember what these are, because I did see people with these this week. Shortness of breath, headache, fatigue, lightheadedness. It's not going to happen a week after you had COVID. This is something that's going to happen maybe 2 to 3 to 4 months later. Treatment of long COVID is focused on the dysautonomia, by which we mean blood pressure and heart rate variations, the symptoms I suggested in that last slide. You don't have to get all of them, but enough of them make it easy to qualify for this diagnosis. Tony's tip of the week, please check with your pharmacy for your prescription refill, because there have lately been a lot of authorization delays from insurance. So even if we did the prescription, doesn't necessarily mean you're going to pick up that pill if your insurance is sitting on it for 2 days trying to decide if you should get it. There's also a great lack of supply in the pharmacies right now. So the reason you may not get your prescription is not because we didn't call it in. It's because the pharmacy just doesn't have it in stock. Also, back orders are existent on a lot of common drugs right now. Remember also that prescriptions for controlled substances, Ambien, Adderall, Ativan, are actually being watched by DEA for multiple across state lines prescribing. So I know many of you might be in different parts of the country at different times, and some people go away for the summer. But now DEA does not like to see controlled substance prescriptions being prescribed to multiple different pharmacies for one patient, and they definitely are tracking doctors for that. So if we do too much of that, we doctors will get in trouble with the DEA. So try to stay with one pharmacy for these kind of prescriptions. Fast pitch, COVID might be a common cold. That's certainly what everybody is telling me. Paxlovid works, but might have even a higher risk of rebound, maybe as high as 30%. We are still in a huge COVID surge that's probably been going on since the end of March. Masks can prevent infection. A booster doesn't, in particular with Omicron 5. If you just had Omicron a couple months ago, your antibodies aren't going to neutralize Omicron 5. Only a mask is going to protect you from infection right now. And then pack wisely for overseas travel, because there certainly are a lot of people overseas. Remember to keep track of your health pyramid. Make sure that you've addressed all these things at your annual physical. Our book is still available, and click to subscribe and you will get these to your inbox. Thank you very much.